Thank you for the introduction. A very good afternoon to everyone again. So my topic today is to talk about, my role is to talk about de novo brain metastasis in lung cancer. There is going to be some amount of overlap because the last couple of talks have covered most of it, and these are my honest disclosures, so please bear with me. So the outline of my talk is this. I'm going to talk about the incidence briefly, and I'll also talk about the various treatment options that are available in patients who have de novo brain metastasis, and how do we prognosticate these patients when we are deciding on their treatment, and how do we change their treatment or tweak their treatment in the context of the therapy that they subsequently receive. And also we'll see about a few special situations. So we have heard about lung cancer having a high incidence of brain metastasis, and this is possibly because the tumor cells per se are fertile seed, and also the brain provides excellent breeding ground for these fertile seed. Generally, the location is in the gray-white matter junction, and the commonest location is in the cerebral hemispheres. While NSCLC as such has high incidence of brain metastasis, the incidence is even more higher in patients with EGFR, ALK, or ROS1 metastasis. As high as 30 to 40% of these patients can have brain metastasis at presentation, and some more do develop more brain metastasis during their treatment. The cause of this high incidence is not clearly understood, but it could be because of the fact that these patients have a higher survival than your non-muted patients. So they're going to survive longer. You're going to image them much more frequently. So that's the reason you're going to pick up these metastases. Also, the conventional older agents that have been used, the systemic therapy, have traditionally known to have poor CNS penetrance. And also there might be some tropism which is poorly understood, which could lead to this high incidence. So what are the treatment options that we can give these patients? Broadly, they can either receive local therapy, or they can get systemic therapy, or best supportive care, all in combinations or in isolation. So the treatment principles, how do we guide our treatment principle when patients present with brain metastasis? Historically, what has been the thought process is that these patients who present with brain metastasis have a poor prognosis. So there has been a therapeutic nihilism saying that anyway, they're not going to do so well, because this is all based on older reports where they found that patients who receive whole brain RT or steroids don't survive for more than 3 to 6 months. However, last few decades, we have seen that we have made leaps and strides in terms of therapeutic advancements, and also the molecular profile has completely changed how we treat these patients with lung cancer. And what is also important to remember is many of these patients who present with brain metastasis have a significant symptom burden, which adversely affects their morbidity and also impacts their mortality. So it is very important that we address these brain metastases and not sweep it under the rug. So the principles that we use while we are deciding on the treatment options are that we make sure that we reduce the symptoms as much as possible. And also while we are choosing the treatment, we also try to improve the local control as much as possible by preventing local recurrences and also the intracranial failures. At the same time, we do not want to increase their toxicity, increase the treatment-related toxicity, both acute and chronic. And ultimately, we want to improve their patients' quality of life, and to a certain extent, also try to see if we can improve the survival itself. So the treatment options that are available, the first and foremost, which has been time tested, is the surgery. Surgery, the place for it right now is that we restrict to patients who have large metastasis, who have symptomatic disease because of mass effect or the location per se. If it is in the posterior fossa, we do surgery for these patients. And typically these are solitary metastases with a good general condition and controlled extracranial disease. And sometimes it also serves to provide you with a histological confirmation. And in certain patients who have radio-resistant histology, the perceived radio-resistant histology, these patients could undergo surgery. So with the recent advancements in neuronavigation and guided surgeries and intraoperative monitoring, surgery is no more as morbid as it used to be. Despite good surgery, post-resection, many of these patients can develop recurrences as high as 50% at 1 to 2 years. The other commonly used modality is whole brain RT. It's one of the unique things that in patients, regardless of how many number of lesions the patient presents in the brain, we have been historically treating them with whole brain radiation, as opposed to somebody who presents with the lung metastasis or the liver metastasis. We don't treat the entire organ, but here we do. And this is basically because many of these patients have significant symptom burden, and you have a poor poor prognosis, and you know that the systemic therapy is not going to penetrate as well. And also conventionally our techniques were limited, so we used to treat them with whole vein RT. But one of the advantages of doing whole vein RT is that you have micrometastasis which can be lurking in the brain parenchyma, which you are addressing it. And also to a certain extent, whole vein RT can break down your blood-brain barrier, which can lead to better penetrance of your systemic therapy. The downside of all this is that there is neurocognitive decline and also certain acute side effects which we need to deal with. There have been recently certain advancements that we have done. We have tried to do hippocampal avoidance, whole vein RT, as the previous speakers are showing. You can also use either a simultaneous or a sequential boost so that you can increase the dose to the gross lesions as such. And also Mementin, as an NMDA antagonist, can also reduce some of the neurocognitive decline because of whole vein RT. SRS, we have been using ever since 1990. We initially started using it only for less metastasis, but now we are treating as many as 20 metastases with SRS. And what we need to remember is the dose that we use in SRS is basically you tailor it to the number of lesions, the lesion location importantly, and also the volume of the tumor that the patient presents with. And these are some of the guidelines, the RTOG trial, which showed us a way how you could tailor your dose depending on the size of the disease. And the setting of SRS could be either in a definitive setting, or it could be post whole vein RT as a boost, or you could also do something like a SRS followed by whole vein radiation. And post-operative patients also receive SRS. The fourth and the last treatment modality is the corticosteroids, which is largely underutilized or sometimes overused. It can waver between these two. What it does is that it basically stabilizes the blood-brain barrier and thereby reducing the cerebral edema and improving symptoms. And you have various guidelines as to how you need to go about administering these corticosteroids. Generally, we prefer dexamethasone because the mineralocorticoid activity is slightly less. So the evidence that has evolved for the treatment of brain metastasis in lung cancer is that these trials have compared between various combinations and in various settings. And we have trials which have looked at whole vein RT versus best supportive care to trials which have treated more than 30 brain metastases. I am not going to bore you with this table, but what I'm trying to show here is that this is a table which shows various studies which have compared whole vein RT with local treatment and whole vein RT. And what generally they have shown is that you improve the local control by giving an additional focal therapy, and possibly you improve the overall survival in patients who have solitary metastasis. Can you do away with whole vein RT? So these are the list of trials which have looked at local treatment alone versus whole vein RT plus local treatment. And what they concluded, I mean, at least what I could infer from these trials is that they definitely improve the local control, or the local control between SRS versus whole vein plus SRS is similar, or it could be slightly more with SRS because you're delivering a higher dose, but there is no survival benefit. And of course, because you're not treating the entire brain, your neurocognitive outcomes are much, much better. So where we have started is that we are using whole vein RT where you had patients who had limited survival. So your priority was trying to get their intracranial disease under control, but you ended up having neurocognitive decline. But now we are kind of moving away. We have moved away to concentrating on focal therapy, where because you have long-term survivors, so you want excellent local control along with neurocognitive preservation. So Dr. Upasana has again gone through this prognostication, how we go about. So the initial the RPA classification was for, mind you, all disease, and the Sbrt 2008 paper, the GPA was again for all diseases. So they used various factors. Let me just skip these lesions. This is the most recent. I strongly suggest the students at least to go and look at this paper. So where we have ended is that how we choose the patients is based on their physical condition and their disease burden and the biological view. So these three things are important while you're considering what kind of a treatment you are going to offer to these patients. And there are various decision trees which I'm not going to go and look at. But once you've chosen the right kind of patient, it is not just the patient alone whom I mean, that's not the only factor which will make you decide what kind of a treatment, what you're going to do. It also depends on in which context are you going to offer your radiation. So if a patient is going to get systemic therapy, you know that traditionally, historically, it's not going to be a great CNS availability unless you are using certain agents like pemetrexed and carboplatin, which have a slightly a better objective response rates within the brain. If not, you would definitely want to do whole vein RT or even SRS for these patients who are receiving only systemic therapy. Targeted therapy has completely changed the game. We know that the CNS penetration is progressively it is better with the higher, the newer generation molecules, both in EGFR and ALK-TKIs. And there are multiple studies which have looked at it, and what they have shown is that the objective response rates within the CNS and also the median duration of response are as high as 90% in osimertinib and lorlatinib, and also the duration is as good as 1.5 to 2 years. So that is what we need to keep in our mind as to whether these patients are going to get whole vein RT alone, or do we going to give these patients only SRS. But what you also need to remember that when you're looking at these trials, there are a lot of heterogeneities, because many of these, the way they randomized patients and recruited patients are largely variable. So what you need to also remember at the end of the day is that if the patient is going to receive only TKS, it is going to give you a good durable response, but still it's in the range of 12 months, 1 year. And many of these patients are eventually going to fail. While you have a modality like SRS or whole vein RT, which gives you excellent local controls, why not combine them whenever there is an option? So asymptomatic brain metastasis, I know you might be expecting me to give you a final word on this, but we do not have as we stand. One of the options is to give TK and early radiation. There are certain trials which are looking at it. Hopefully in the next couple of years, we'll have some idea where we are in this setting. There is some risk of increased radionecrosis, especially when you use certain agents like erlotinib along with SRS. So this is again something you need to keep at the back of the mind. So this is what we generally follow in our clinic. When patients are symptomatic, we definitely offer them local treatment along with the systemic therapy. But if they're asymptomatic and if they have a driver mutant disease, there is an option of giving them a third generation TKI and reserve RT for later, especially if the lesion is small and not causing them issues. Now, with the advent of so much of immunotherapy, we need to again see this in this context. Although CNS is regarded as an immune privileged site, it is not really so, because some of these studies have recruited patients and have shown the value of intracranial, the value of the checkpoint inhibitors, even in reducing the brain metastasis rates. As Dr. Nikhil was showing, there is a slight issue when you combine ICI and radiation, although you might think that it increases the antigenicity and the response should go up, but there is a slight risk of radionecrosis. Is even more important when you're considering certain histologies like melanoma, and if you're combining with ipilimumab, there is definitely a higher risk of necrosis. Leptomeningeal disease is something that you should remember about. Many of these patients, not a very great majority, but small percentage do present with leptomeningeal disease, slightly higher incidence with your driver mutants, and they traditionally have a poor prognosis. You do offer them chemotherapy, intrathecal methotrexate is something that has been tried, and we do not generally offer whole vein RT unless they are symptomatic or they have some focal disease which you want to address upon. So to summarize, we have kind of moved from where we were in therapeutic nihilism, where we were not doing too much, to now in a situation where we are spoiled for choice. We have so many options, and it's hard to choose between these agents. But we need to be careful in how we choose these patients for what kind of a treatment, and we need to understand to a certain extent, try to understand what their tumor biology might be, and the future definitely looks optimistic. Thank you for it.
Thank you, Naveen. It was very informative.
Okay, thanks, Naveen, once again. I would like to call upon the next speaker, Sridhar ES. He is a senior consultant radiation oncologist at HCG.